Good evening. I welcome everyone. My name is Ivan Davila, and I'm the Director of Communications and Community Engagement here at Central Health. If you are here on a Monday evening, that means you really care about improving the healthcare of our community. So thank you. That means we all have that in common. We really appreciate you being here this evening. Si están aquí es porque en realidad les importa el mejorar los servicios de salud de la comunidad. Si necesitan servicios de traducción, tenemos servicios de traducción acá atrás, así es que por favor vayan acá con las señoritas. We're trying to do a better job of having translation services at these community meetings. As you can see, there may be one or two people or sometimes nobody using these services. This is so that we can create a culture of welcoming more people into these community conversations. We want to make sure that people feel welcome and that they feel included. And so hopefully more and more people will be joining us in these conversations as well. Okay, a couple of housekeeping items. As you saw, there's some food in the back. There's water, coffee, and tea. The restrooms are, as you exit these doors, they'll be you take a right, and then they'll be on your left. And with that, we're going to go ahead and show a video before we get started.
Central Health is the public agency that ensures Travis County residents with low income have access to the best possible health care. We do this by working with a network of partners, including Community Care, Sendero, and the Community Care Collaborative, Central Health's nonprofit partnership with Seton. These partners make up the Central Health Enterprise. In 2016, Central Health funded care for about 1 out of 10 Travis County residents, nearly 144,000 people. 96% of Central Health's budget goes to healthcare delivery. Central Health is creating a coordinated healthcare system that provides access to care in new and innovative ways, from community-based clinics and a new state-of-the-art teaching hospital to mobile and virtual healthcare. The Central Health Enterprise nurtures a healthy community by providing better outcomes for patients, not just paying for more doctor visits. How do we do it? Central Health funds community care health centers, the largest network of clinics in Travis County devoted to caring for people with low income. Central Health also partners with Seton through the Community Care Collaborative to share resources and provide high-quality, cost-effective care for residents with low income in hospital and clinical settings, creating a true safety net of care. Central Health's Medical Access Program, or MAP, helps Travis County's lowest-income residents get health care. With MAP, doctor and hospital visits and prescriptions are covered. And through Sendero, Central Health's nonprofit health insurance plan, about 75,000 people have received health coverage since 2014. Through these collaborative partnerships, Central Health is delivering on its promise to Travis County taxpayers to reinvent healthcare by increasing access to quality care, reducing costs, and creating a model healthy community. To learn more about how we're transforming healthcare in Travis County, visit centralhealth.net. Also follow us on social media.
All right. I do want to recognize some of our board members here present. Manager Cynthia Valadez, we have Manager Musaitif, and Manager Jones. Thank you all for being here. All right, so here's what we have in front of us this evening. We're going to talk a little bit about the Central Health Enterprise. You saw a little bit of that already in the video. We're going to talk about the budget timeline, and that goes all the way through September, the end of September. And then before we dive into the actual budget and the ins and outs of the budget, expenses and revenue and expenses. And then we're going to be taking the majority of this evening's meeting to talk about 2018 accomplishments and gather some of your feedback. That we can then incorporate into the budget development process as well. And then we'll wrap it up with next steps. All right? Let me hand it over to our President and CEO, Mike Gislin. Oh, I am so sorry. Hold on a second. Mike, I am sorry. All right. So everybody has a clicker on your chair, or when you walked in and before you sat down, you saw a clicker that looks like this. During the feedback gathering section of this evening's meeting, we're going to be using this clicker. So we thought we should go ahead and do a little test run with y'all before we get started. So go ahead and turn them on, and there's a little power button there, so turn them on. It'll take a few seconds before the screen says ready. So just wait a few seconds until the screen says ready. Okay? And now, when it says ready, please answer this question. What's your favorite comfort food? We've got 4 options there: pizza, tacos, hamburgers, and all of the above. Please note that we did say comfort food because we are a public health entity. We have about 18 people in the room, so we want to make sure that it goes all the way to 18 if possible. If not, then we'll take 15. One more? All right. So this is how it all works. Does anybody have any questions about how the clickers work before we get started? You just push the letter, and that's it. You don't have to push send. You just push the letter. You can also change your vote, but then once you click a letter and you're committed to it, we'll go with it. All right? All right. Now we're ready.
And what we'll do is Ted will lead in the voting, and we'll announce close and give you a few seconds to cast a vote. But I want to thank you all for coming out tonight. And this is a community conversation, and this is the kickoff of the budget process for us. In fact, we had our first internal staff meeting today to learn how we're going to start building and developing the budget. But we wanted to bring you in at each critical phase of this process and tell you what we know. This is what we know to be the case fiscally in terms of what's happening in healthcare finance. But also we wanted to bring some big questions to you. You'll have the chance to use these audience response devices, or these clickers, later on in the presentation because we have some kind of just bigger, larger questions to say, big picture, what do you think about this? Before we get into any numbers or start analyzing any finances, this is not the meeting where we actually present a proposed budget. That comes later in July. Thank you for not leaving having heard that, so I appreciate you staying put. That means a lot to us. But this is where, again, we start forming our knowledge base, which builds the budget. So as you saw in the video, we talked about the Central Health Enterprise, and I'll move around a little bit so you can see the screen. But when you think about Central Health, we are a government agency that is created as a special purpose district in law, but we have affiliates or enterprise partners, as we refer to them. And as you can see the chart here, and the way to think of this is that these are all individual organizations. They have their own boards, they have their own management teams, but they're all part of the Central Health Enterprise. So starting here on your left is Community Care. This is the largest federally qualified health center in Texas and our largest primary care provider. They see about 80% of our patients by volume in over 26 locations, including walk-in clinics as of late. So we're always working with our partners at Community Care to expand those service offerings. Then you have Sendero Health Plans. This is our nonprofit community-based HMO. They're currently insuring about 15,000 plus or minus people here in Travis and other adjoining counties. We talked a lot. We had a community conversation around Sendero last week. Those of you that attended, thank you very much for coming out for that. That was very helpful and informative. And then there on the far right, we have the Community Care Collaborative. This is our partnership with Ascension Seton. And what's interesting, or what's significant about that partnership, the Community Care Collaborative, is this is where almost all of our primary and specialty care contracts reside. And the Community Care Collaborative is a place where we bring funds together. We put money into the Community Care Collaborative. Ascension Seton puts money in. We bring down federal dollars through a matching program. And so we pull all that money together, and that's what enables us to leverage resources for primary and specialty care, but also what you refer to as DISRP or demonstration projects, where we're actually caring for patients real time and figuring out how do we improve care. So when you hear it on the video, delivering on our promise to change care, this is where it's happening right there in the Community Care Collaborative. So that's our enterprise. And then we mentioned partners. We actually partner with over, if you count the contracts and all the affiliation agreements, we partner with over 200 people, 200 organizations or entities. But these are just some of the names that you may recognize driving around town that we partner with both on the primary and specialty care side and integral care on the mental and behavioral health and brain health side. So this is our budget timeline, and I'll hand it over to Lisa.
All right, good evening. I'm Lisa Owens. I'm the Vice President of Financial Operations. Thanks for being here tonight. So as we talked about earlier, this is the kickoff to our kind of concentrated budget planning, but I would say we are working on the budget year-round, reporting and monitoring, and our teams work with the community on an ongoing basis to incorporate the feedback at many of the meetings throughout the year into our strategic priorities that are funded through our budget. So with our conversation tonight, we begin a more concentrated effort to gather the feedback about our strategic priorities from you as we can incorporate those into the budget in the upcoming years. So looking at the timeline, here in April. In April and May we will be having these conversations internally. As Mike said, we kicked off the budget with our leaders today internally. But also we will have an online survey available, so the activities tonight and the questions will be available to others, so please spread the word. As well, you'll see at the bottom and in the information you received in your handout, we do have a web page that we will be keeping all of our budget information on as we go along, so please save that URL and share it. Into May and June, we start to look at our long-term forecast, and the Board of Managers gives management feedback on how to draft the budget by giving us guidance on a draft proposed tax rate. As we talked about, in July, we prepare a proposed budget, and we'll come back for a community meeting in July to talk through what's in the 2020, fiscal year 2020 proposed budget. And then throughout August and September, we hope you'll keep up. Most of our meetings will have the budget on the agenda, our public meetings, as well as the public hearings that we host, with the final establishment of a tax rate and adopted budget no later than September 30th. So as Yvonne talked about, tonight we're going to talk through our current year budget just to show you how we structure the budget and incorporate our strategic priorities into the budget. And this will give us feedback from you as we go forward to bring you back that proposed budget in July. So sources of funds, we do have three main sources of funds. I'm going to stand kind of here. Revenue-wise, that is property tax, lease revenue, and then other revenue. And for those three combined, the property tax revenue is our largest source of revenue. In addition, we have a contingency reserve, which is available sources of funds in order to provide healthcare delivery. On our uses of funds, 96% of our uses of funds are for healthcare delivery, and then just 4% for administration and tax collection. When we're preparing the budget, one of the things, as I mentioned, our largest component of our sources of funds being our tax revenue, we look at a proposed tax rate, and we consider the efforts that we're working on to maintain a low tax rate as well as provide additional services, healthcare services to the community. So as an example, in FY 2019, we are showing you here the increase in the tax rate, and that, that increased 6% over effective last year. So effectively over what the taxpayer paid, 6% year over year. And as you'll see down below, that was about $16 on average to the average taxpayer in their property tax bill. So that's an example of the considerations we take in when setting that tax rate. Yes?
Where does the contingency
The contingency reserve is available resources that roll into the next year. So it's our reserves as a source of funds. It's reserves at the end of the year, our sources over funds. Those funds are available in the next year. Yes, it would be previous year tax revenue. That's. So as we talked about on the uses of funds, 96% of our uses of funds are for healthcare delivery. And we work very hard to increase the funds available for healthcare delivery by matching programs, such as a program called intergovernmental transfers. And this is an example of how Central Health has local tax dollars and this is from last year, 119 million local tax dollars are matched by federal funds of 157 million, and that allows us to provide over $270 million in healthcare services for low-income families in Travis County by delivered through our healthcare partners, such as hospitals, clinics, and the Community Care Collaborative. So we work to take the local tax dollars, use matching programs that are available to leverage those funds and bring more funds into the community to fund healthcare. So a few highlights from our other uses of funds looking at this current year budget. Next slide. As I mentioned, the matching program, intergovernmental transfers, pays for uncompensated hospital care in DSRIP. That is over 56% of our budget in the current year. In addition, we fund primary care, behavioral care, health care, and specialty care, as well as women's health through our partnership, the CCC. That's over 40 million, or just about $40 million. And then other initiatives include, I'll just hit some of the major highlights, but it does include our redevelopment of the downtown property. And you'll see we drew an arrow there that we had shifted that from an initiative to an operating expense, but the funds are there to redevelop our downtown property, which we will use those revenues to provide more health care to more persons in Travis County. And then other areas are things like the Affordable Care Act, education enrollment, and our premium assistance programs, which offers premium payments for persons enrolled in the marketplace programs. The revenue that we receive is a source of funds under lease revenue. And then the funds that we spend to redevelop the property are a use of funds. So all these different uses of our funds support our strategic work plan. And now I'm going to hand it back to Mike, and he's going to walk through our current objectives.
So the key takeaways from the previous slides are we match federal dollars. We take local tax revenues and some of our lease revenues, and we use that to bring in federal dollars to fund hospital care. And then we also use that same strategy to fund our primary and our specialty care. That's the essence of what you just saw. The question is, what is that supporting? So last July, the Board of Managers adopted a new strategic work plan that was built around 3 objectives. Previous to that, we were working from a priorities-based plan. It had 19 different priorities, but the thinking was we really need to organize it under objectives and put it on a much longer time frame, because there's a lot of things that change in healthcare. And while the objectives may not change, the strategies might in terms of how we get there. But tonight I'm just going to cover the objectives. 1, develop and execute a healthcare delivery strategy based on people in place. You'll hear us use the phrase, this is about the geography of health. And it can be about locating bricks and mortar clinics. It can be about locating temporary clinics for a short period of time until you get a longer term solution. It can be transportation, so connecting patients with care. It could be about telemedicine. There's a number of different programs so that we can work with our providers to meet people where they are and how they are in the community. And again, it's not just about a building, it's about bringing health to people or connecting people to health. Objective number 2 is implement a coordinated and patient-focused healthcare system. You will hear the phrase integrated delivery system a lot, or the acronym IDS, and you'll see this thrown around in healthcare circles. But honestly, I like to say coordinated and patient-focused health, because at the end of the day, if we're not building this around the patient and we're not coordinating the care so that it's easier to navigate the systems that we as patients are in, then what are we doing? And so I think it's important that at the end of the day, when one of the people that we're privileged to serve walks in through the door, that everything that they need is coordinated and built around their needs, not necessarily what the system is capable of producing. Now, this is a tall order, and it's going to take a few years for us to get there, but this is an objective that we're absolutely dedicated to. And then objective number 3, implement sustainable financial models through 2024. There's a lot changing in the way healthcare is funded. There are changes in federal rules that will be happening later this summer, early part of the fall, that are affecting how we fund healthcare. And it's important. You ask about the reserves. That was an excellent question. So every year, unspent amounts roll forward into the next year. We also budget for an emergency reserve just in case. This is why we do this. And I think we're about to see first time in this community why it is so important to have reserves, because all it takes is just one change. And what you see is unfortunately a very complicated funding model. We hope to simplify it, but all it takes is one change to where it threatens the stability of the model. Now, what does that mean? Well, if you're an individual and you're seeking care through our system that we work with our partners to deliver, we want to make sure it's going to be there for you year in, year out. You shouldn't have to worry about, will this clinic be here? Will this provider be here for me? And so we want to make sure that we have a sustainable financial model that ensures that we're going to be there in the community as we should be serving people. So that's our 3 objectives. There's a whole host of strategies that line up under these, but that's a different meeting and a different night and probably a couple of hours, and so we'll move to the next slide. I'd like to introduce Larry Wallace.
And Larry, if I may, Ted Burton, Vice President of Communications. As we move into this next section, we want to encourage you to ask questions, but it's important that you let me bring a microphone to you because we are broadcast live streaming this, and it's live on our YouTube channel. So as Larry begins his presentation and we move slide by slide, if you have questions, raise your hand. I'll bring you the microphone. We just ask you to identify yourself and then ask your question.
Thank you, Ted. My name's Larry Wallace. I'm Chief Administrative Officer for the Central Health Enterprise. And I want to talk to you a little bit about some of the work that has already began to address some of the issues in Eastern Travis County. Everybody in this room know that affordability is a major issue in the city of Austin. And more and more people are having to move outside of the center core into areas surrounding Austin. Our board a year ago, a little bit more than a year ago, in 2018, made a commitment that we would proactively take steps to address some of the shortages that currently exist in Eastern Travis County. Our primary focus points were in Del Valley and in Colony Park. Del Valley has really suffered many years with a lack of services, not just healthcare, but basic infrastructure. And when we do our work, we find that we can't solve all the problems, but when we talk about healthcare, we certainly bring people along with us that can take care of those other problems for us. I'm proud of the fact that you heard Lisa say 96% of our dollars go directly to care. I don't know of any other hospital district in the state of Texas that can make that claim. That's huge, and I think that shows, and that speaks to our board and to this community on really what's important when we talk about healthcare. And you support that, but I think it's really important that you know where your money goes, and it's for healthcare. We created a few years ago through here at Central Health an organization called the Eastern Travis County Healthcare Coalition. And it started out with really 3 agencies. It was the City of Austin, Travis County, and Central Health. And what was common was we knew that we all served the same people, and we knew that there were a lot of shortcomings, and we also knew that neither of us could really address the problems alone. And we decided that we would come together and do some joint planning, talk about what the issues were, bring all of our resources to the table, and leverage each other. And out of that, we were able to come up with some strategies that are really in play today. That group has gone from 3 agencies to over 20 different affiliates that meet on a regular basis. And our purpose, our sole purpose is how can we bring health services to the low-income, underserved residents in Travis County. So we're real proud of that group, and people come and they bring their ideas. I want to talk about some projects that are underway in Del Valley, which was one of our focus areas. First of all, the Travis County was very gracious to allow community care to partner and to use the clinic, the employee clinic, which is over on 971, I believe, is that right? 973, okay. It's real close to the jail, I think, over in that area. And Travis County employees have a clinic there. It was underutilized, and we approached them, and they gave permission, really, for community care to offer services as one of the solutions to the Del Valley population. And Matt, how often are we there now? 3 days a week, and it's very successful. And the good thing is they limit it to people that lived in that area so that they could make sure that it was reaching the desired goal. The second project that is underway serves Austin Colony, Hornsby Bend, and there are a couple of things that are going on that are out of the box thinking. One is the house calls. How many remember when the doctor used to come to your house? Anybody other than me? I'm the only one? Okay, thank you, I hope. I remember Dr. Owens coming to our house with his big black bag, and it's full of medicine, and he'd give us shots, and I mean, that's how we got our health care. And, you know, many, many, many years later, I won't say how many, we have gone full circle. And so community care sponsors house visits. It's specifically targeted to that community. It's a pilot, and we're really curious to see how it works. It's offered 3 days a week. I think it's Thursday, Monday, and Wednesday. Okay, all the way up until 8 o'clock at night. It's a nurse practitioner, and so all you have to do is make a call. Where else can you get a deal like that? And so we really appreciate that effort by community care. The other project is on Kellum Road, where we are in the process of working with the UT School of Nursing and perhaps one of the emergency service districts to create a presence there. And then thirdly, I want to talk a bit about Colony Park, which is one of our areas. We opened up what we call the Northeast Health and Wellness Resource Center, and that is a collaboration between the city of Austin, Travis County, Integral Care. We have other partners that have joined in along with community care. And so that's a resource, and it's an interim step. A much larger effort is a new health center that will be located in the city-sponsored Colony Park Master Development Project. That's a huge project, over 230 acres, probably more than that. But we have 5 acres that has been dedicated really for a new health center. And our vision for that health center would mirror what we have at Southeast Health and Wellness Center. We want something that is full service, that offers a full array of services. And there's also plans to have space for our partners to join us in that space. That project is moving. We have to depend on the city of Austin to move that along. That's a development. But I must say we've had good cooperation from the city of Austin, and we're very optimistic. Another item I'd like to tell you about is Central Health has purchased a new 40-foot long mobile RV clinic. and it will arrive here on Friday morning if all things work according to plan. It's a great unit, and we're real proud. And you'll see it showing up sometime in June. It will serve Creedmoor, which is one of our areas in Del Valley that we are really concerned about, as well as Colony Park. The unit will share time between those two locations. And the good thing is it's on wheels, so we can take it anywhere. And so once we get permanent facilities located in Del Valley and Colony Park, we can take it elsewhere. There are other communities that also need services. The last project I want to talk about is the Community First Village. That's Alan Graham's program to get homeless folks off the streets. I don't know if you've ever been out there on Decker Lane, but it's a very, very positive project. And we have the privilege of working with Alan to provide the leadership on program development. Community care and integral care are the primary providers in that location. And it's really going to be an exciting project, and we're really happy to be a part of it.
Larry, can I ask you to touch on one more project? You only hit about 30 so far, but the Modular Clinic that's going to be placed in the greater Hornsby Bend area?
Sorry about that. And again, yes, ESD4, I believe, is who we're partnering with, and they're allowing us to locate a modular on their site. And again, this will be community care operated, and I think we'll even have enough space for some of our partners to provide some services. And that is underway, and Ted will keep you posted on progress and delivery times and openings. Is that it?
You, Larry.
Okay.
So we are going to first move to our first Instapoll. So if you wouldn't mind holding up your clicker and reorienting yourself with that. We're going to ask you a quick question here. So Lisa talked about our finances and resources. So now you get to play Board of Manager. With limited resources, and there'll be 3 separate questions, so you're going to vote on each one separately, and I'll walk you through it. With limited resources, how would you prioritize spending on the following? So the first question, and it's going to be an A, B, C, or D answer. The first question is build more what we call brick and mortar clinics, so permanent health centers. Would you rate that as A, very important, B, somewhat important, C, not important, D, not sure? And we are going to capture these responses back here on the whiteboard, and we can discuss them further and then also provide them in a report out at the end. So it looks like 33% or 6 people said A, very important. 61% or 11 people said B, very important. I'm sorry, somewhat important. And then 1 person voted not important, and nobody could not make up their mind, double negative. And I think we'll close that poll. So with that, anyone want to take the microphone and tell us why you voted for the way you did, either very important, somewhat important, or not important? Anybody want to talk about that? Building brick and mortar clinics? Well, should we go on to all the questions and come back, or just do this? Yeah, let's do all the questions and we'll come back and we'll have a conversation. So we're going to go to the next question. We're clearing the poll. Clicker's ready. The next question is invest in alternative healthcare solutions, for example, telemedicine, where you could talk to your doctor or go to your clinic via your mobile device or on your computer. Mobile clinics, which is what Larry talked about, when we bring healthcare to you via an RV or a van. And then house call services, the home visit pilot that we're doing now in the greater Hornsby Bend area. Would you list those as very important, somewhat important, not sure? That was an overwhelming response. 18 people, 95% said very important. Okay, we're going to clear the poll and go to the last question. Pay more for transportation to and from clinics. For example, our Lyft pilot program, where we're providing rides to medical appointments at the Southeast Health and Wellness Center, shuttle services. So pay more for transportation to and from clinics. Very important, somewhat important, not sure.
Is the assumption that this is for people who need the financial support for the service?
The assumption is it's for people that we serve, our patient population, so people with low income who are uninsured. And so for that response, I'm not good at adding up if everyone voted or not, so somebody else with a math brain can do the math, but A, very important, 6 people. Oh, thanks, Yvonne. B, somewhat important, 11 people. Not important, 2 people, or 11%, and nobody was not sure. And as Yvonne points out, 100% of the precincts are reporting. So let's go back and talk about this. And again, there is no right or wrong answer, and this is not a either or necessarily conversation, but really more of a way for us to hear from you what your priority, what you think the priorities should or might be. So who wants to talk about that? Building more permanent clinics, focusing on alternative healthcare solutions, future solutions, investing more in transportation. Anybody have a question or a comment? Thanks, Joanna. Just say your name and then say your
My name's Joanna, and I voted lesser importance for the brick and mortar because of the rate that we grow, or that we've been growing in Austin. It seems like we outgrow what we thought was going to fit just right. So maybe to spend more on the 2 and 3 for that reason.
Dr. Moody.
Charles Moody. I voted somewhat important on the brick and mortar, and I voted really important on the alternative health because of the fluidity of our community and the fluidity of the kind of people that we serve. Each community has very specific needs, and so we have to think about those individual needs and kind of tailor it to fit.
So there's not a one-size-fits-all approach. Anybody else have any thoughts or questions, comments? Please.
I'm Howard Falkenberg. I agree 100% with the gentleman for the same reason. I voted the same way.
Good. Mia?
Mia Greer, for 3, pay more attention to transportation to and from clinic. If we tailor it to the individual, you will know better about the transportation issue. So if it's a community who would rather have their house calls and mobile clinics, transportation won't be an issue. But if they would rather have a brick and mortar and they're a little further, then that would be an issue. So again, that transportation question is the same. It's not a one size fits all.
Thank you. Eric? Simple question.
And I agree. I said somewhat important for number 1 and very important for number 2. However, I throw in the caveat that I think we do need to have an emphasis on behavior change for our patients, because I think the expectation as a standard at this point is that we use brick and mortar for our clinics, but we are trying to change over to some of these other modalities such as telemedicine in order to go and follow our population that is moving out east. So again, I think the caveat has to be is setting the expectation and working with our population to change that behavior of how healthcare is delivered.
And does everybody understand what telemedicine is? That we have a common definition of that in the room? Just making sure. Frank?
Frank Rodriguez. I think I prioritize all 3. I think the brick and mortar really, so when you have suburbanization of poverty, you have a shifting population, and then you have gentrification occurring. And I know there was some mapping done recently where it showed that some areas gentrifying faster than other areas. And so I think a clinic presence is really important, culturally also for the community. But I think more in the context of leasing space so you can move if you need to. And the alternative healthcare solutions is really important for that reason. And then the transportation, again, as people push further out in a suburban manner, there's no transportation system out there, so you need the services.
Thank you. Thank you. I'm going to move us along unless I see a hand. Okay, so I was told I'm not allowed to throw any curveballs. Lisa's next, but Lisa, would you explain what population health is?
No, there's not a universal definition. We have some information in your handout, but what we do know is that 20% of an individual's health is determined in the doctor's office, and a lot of social factors or factors that affect specific populations play a larger role than what happens in your doctor's office. So this is an area that we have been working on exploring different opportunities with our board of managers, and we're still in the exploratory stages collecting data to determine our role with our partners in the community in population health and those social determinants of health such as transportation, access to food, and activities. But one of the areas that we've been very successful is with our Health Equity Policy Council. And last year, for example, we worked with local school districts and our policy council to implement recess policies that encouraged physical activities in the schools. And then at the same time, another highlight for all of us in the enterprise is our summer lunch program. And this is at our Southeast Health and Wellness Center, and all the partners contribute to the support of that. But we provided over 4,300 free meals to children and their families throughout the summer lunch program at the Southeast Health and Wellness Center. So those are some of the highlights of the work that we're doing in that space as the priorities in population health are developed.
Thank you, Lisa. I'm Michelle, the heading of the Director of Health Insurance Enrollment and Training. So thank you for being here tonight. One of Central Health's core functions is to assist our low-income and uninsured residents enroll in health coverage. So Central Health funds the Medical Access Program, better known as MAP. We also assist with enrollment into qualified health plans offered through the health insurance marketplace. So in 2018, Central Health enrolled over 46,000 residents into our MAP program, providing essential coverage in primary care, specialty, dental, hospital, and behavioral health services. We also provided assistance with health insurance premiums for over 2,200 residents, 1,500 of which were local musicians who are members of our Health Alliance for Austin Musicians and the Sims Foundation. And most recently, our Central Health Board of Managers voted to increase funds up to $6 million so that we could add additional premium assistance and offer it to our most critically ill MAP clients and give them the option to move into Sendero health plans where they could have full insurance benefits, access to broader network and specialists, and in turn, this would give Sendero the option to draw down more federal funds according to their risk adjustment. So in 2018, Sendero worked with over 2,500 local providers to deliver $125 million in healthcare services to their members. So providing health coverage for our Travis County residents is definitely one of our top priorities. So you've heard about all the great things we're doing to expand services and clinics and a variety of sources to provide primary care. So let's talk a little bit about health coverage. Ted's gonna ask you a few questions.
Okay, get your clicker ready. So Michelle touched on the Affordable Care Act, and last week at our community conversation about Sendero, we provided an update about enrollment numbers for Travis County. I don't have them memorized. Michelle, I'm sure does. But enrollment was down slightly for this year, but just slightly. So with the uncertainty around the Affordable Care Act, as you know, there have been threats by some in Washington to eliminate the Affordable Care Act. How should Central Health respond if, and that is an if, it goes away? A, pay health insurance premiums for residents with low income, as Michelle described, the Premium Assistance Program the board funded this year. B, expand local health coverage programs like MAP, and in fact, we have already expanded MAP to include MAP Basic, and we can talk more about that. C, both. Or D, maybe you have some other options and you want to talk about those tonight. I'm doing the math. We have a few more outstanding votes. Anybody else going to vote? We can close that now. So it looks like the majority of people in the room, 81% or 13, said both. Pay insurance premiums for residents with low income, allowing them to move into private insurance, and expand local health coverage programs, which we're doing. And then we had one person just vote A only. A couple of folks said B only. I don't see any other options. Perhaps you were just afraid to speak up and tell us what your ideas might be, but don't be. We had a lot of ideas last week after our Sendero community conversation, just in the hallway after the meeting, folks that had their own ideas of what could be done locally if the ACA were to go away. Anybody have any thoughts or comments on this particular question about what do we do here locally in Travis County if something were to happen with the ACA? Thoughts? Just raise your hand and I'll bring you a microphone. Anybody?
I have a question. Sure. Howard Falkenberg. The drawdown of federal funds, it matches the level of local funds that are provided.
It's different. I can tell. Mike is going to be the expert, but this is the risk adjustment program. So I'm going to really simplify it, and then Mike can come get wonky on me. But insurance companies that have sicker membership can draw down funds. Insurance companies that have healthier members pay into the fund. The idea behind the risk adjustment program is to level the playing field between insurance companies. Mike, do you want to add to that? Okay. So it's different than what Lisa described as the intergovernmental transfers earlier. It's a different program.
Okay, and on the intergovernmental transfers, is that a matching amount? If we put in 40%, they give us 50 or 60%?
And we're actually getting, what was $1.40, is that correct?
Depending on the program, but on average, it's a formula from CMS, Centers for Medicaid and Medicare Services. But yes, it's approximately $1.40 for the programs that we participate in.
Any other questions or comments on this particular? Anybody?
I'd just like to say one thing. I truly don't believe that the ACA is going to go away. I think there will be a lot of people that do not get reelected if their constituencies find that they are losing access to a comprehensive health insurance plan.
We're not allowed to clap, but thank you, Cynthia. Okay, I think we'll move on to the next slide. And Lisa, it's back to you. We're talking next about accomplishments in 2018 related to primary care and specialty care.
Okay, so as we talked about, we fund our uses of funds. About 96% of that goes to healthcare delivery, and a major component of that is to fund our network of providers, and they provide patients access to medical, dental, behavioral health, and prescription services. So our network of providers last year provided over 183,000 healthcare services, and community care alone provided 297,000 alternative visits. So these are visits that provide quicker access to care when a doctor is not necessary, so such as a clinical pharmacist or a nurse visit. And in addition, we work very hard on specialty care, expanding access to specialty care, but also ensuring that we're working on any wait list time for our patients. And so we were able to improve the specialty wait list times in ophthalmology, for example, and we increased access to care by adding some new specialties such as urology and rheumatology. So that is how we have been working in the specialty care space through the different funding sources that we have.
Thank you. So last year, we provided care directly or indirectly through our funding and our partnerships for over 180,000 individuals. That's 1 in every 7 Travis County residents. And through the partnerships that we have through the Community Care Collaborative and others, we're able to leverage these resources. But it's not just about serving the sheer volume and numbers. And although that's something that we're focused on, especially as the percentage of families living at or below the federal poverty level continues to increase, we want to make sure that we have the capacity to do that. But there's also a quality element to it. There's a value element to it. It's not just about going in for a doctor visit or having a home call from a nurse practitioner or a follow-up on an acute care appointment. And so we began looking more and more at patient experience. The Community Care Collaborative, and if you're wondering, there is a real live person that works in the Community Care Collaborative. And this is, there's teams of people that work on patient navigation and case management. And so, for example, if you've been discharged from the hospital, from the emergency room, there are teams that work across providers to make sure that you're receiving the appropriate care, and also navigation services just to kind of work your way through the healthcare system. We've also begun collecting data on patient-reported outcome measures and also patient experience to start measuring those qualitative elements. I mean, yes, if you go in and you look at my lab chart, you can see what the triglyceride levels are or various other health indicators. But at the end of the day, we need to be able to sit down eye to eye with patients and ask, with the people that we serve, so what is your quality of life like? Were you able to do what you wanted to do, despite what your triglyceride levels may be? Or what was your patient experience like in terms of accessing healthcare? And we've recently begun this effort. I would say probably we've had 1 6-month tranche of data in, and we'll be collecting this every so often, but this is done through direct patient interviews and other survey instruments in English and in Spanish, and I'd have to check on other languages as well to make sure that we're capturing that qualitative data, because we want to make sure that it's not just that we're able to serve 1 in every 7 of Travis County residents should they need healthcare services, but it is a healthcare service that is meaningful and impactful in the way that they see it as meaningful and impactful.
Okay, going back to the beginning of the presentation, our third objective in our current strategic work plan does center around stewardship and fiscal responsibility. So, we work hard to balance fiscal responsibility and the growing need for healthcare services. In fiscal year 18, this chart shows a comparison of the fiscal year 2018 rates. We did maintain the lowest tax rate of any major hospital district in Texas. And in addition, you'll see up at the top, the little round circles, that's an estimate from our jurisdiction and those jurisdictions of what percentage of the tax bill was the healthcare district or the hospital district. And again, maintaining that low 4.3% in fiscal year 18. So we work hard in the space of stewardship. Another area where you see a lot of this effort is around the downtown property, working to increase the financing that comes out of that so that revenue is generated through lease revenue and other sources so that we can deliver care in the communities where our patients live. So that's an area of stewardship as well that we're working in. Okay, and just lastly, to touch on our property tax rates, for the average Travis County resident who lives in these jurisdictions, we do estimate that about 4.2% of their tax bill does come to Central Health through their property taxes. And again, working hard to try to balance our tax rates with the demands for services. So this just shows an average taxpayer in Travis County and the estimate of where their property taxes go. So I think considering all the information that we've shared tonight, we have another poll.
So get your clickers ready. This is your last chance to vote, at least for tonight. So based on what you've heard and what we'll discuss, is the amount you pay in property taxes to support healthcare in Travis County too much, too little, or about right? Too much, too little, or about right? The voting continues. Sorry. So we can close it. Some people will quit voting. I hope you haven't fallen asleep on us. So 7 or 54% said it is too little, and 46% or 6 people said about right. Nobody said too much. Okay. Please.
Howard Falkenberg with a question that maybe goes back 3 foils ago. Are homeless people included in service by Central Health? And do they have to register? Because that would be difficult for them, I would think. But.
Yes, sir. So we have, I want to say 10,000 individuals that we serve that are homeless, and that ranges from those that are chronically and severely homeless to those that are, just have unstable housing situations. Now, the number that are chronically homeless that you see living on the streets, that's single-digit thousands, but they are covered under our healthcare programs. And if they're not covered under MAP, the Medical Access Program, then sometimes they're picked up by the Seton Charity Care Policy, by the Ascension Seton Charity Care Policy, and a number of them are covered under Medicaid. They have certain disabilities that qualify them for a Medicaid coverage, but we cover a significant portion of the homeless population.
The dean of the medical school, I heard him say not that long ago that students were going out and contacting homeless people where they reside, if that's a fair way to say it, where they were, and treating them there. And I'm wondering, is that as a result of the work that you do through Central Health, or is that an independent effort by individual student doctors?
Right. And we're privileged to have staff from community care health centers here with us tonight, and they have mobile teams that go out, and I know there's been some discussion, depending on the use of the mobile clinic, could at some point that be deployed for street medicine as well. And then there's clinics that not only down on South First Street and here downtown, where they see individuals as well. But there is a lot, and the other thing that I'll point out is we also have pop-up resource clinics, and those are very successful events where we've staged them here in the library parking lot. We've been at Southeast Health and Wellness. I'm trying to think, we've been at one of the parks just on the other side of 35. And these are great events where you're able to bring not only the care, so they have care teams there where they can come in and see a doctor or a provider, but we sign them up for other services as well, the housing assessments, STI testing, HIV testing, and other screening services to bring not just the healthcare piece, but all these other resources together. But I think what's important about those pop-up events is we're getting outside the typical clinical structures or just kind of randomly driving around and finding people, and we're getting the word out. And there's a great word of mouth on the street where through the Austin Community Paramedics, which is an incredible organization, that they'll go out there and say, hey, we're going to have this pop-up resource clinic over here on Montopolis Drive. Can we give you a ride? And so they'll bring people in and connect them with the care and the resources that they need.
And Mike, if I may add to that.
Please.
So Matt Balthazar, Vice President of Health Center Advancement at Community Care. And through our healthcare for the homeless programs, we do operate clinical services at the Arch, and as part of that, we do an outreach program where we have a mobile or a street medicine team. And so we do deploy our street medicine teams. They go out, they serve patients under bridges. When I shadowed with them and went with them, we were in the Walmart parking lot down off Ben White at I-35, serving patients and providing clinical services to those individuals down there. So with that, as well as our clinical services, the Arch, we take care of quite a few homeless individuals, not just at that locations, but across all 24 of our locations as well.
We have another question over here.
Charles Moody, when I read this question, what kind of was running through my mind was it was difficult to answer because I thought to myself, well, I know the overall numbers that we're reaching or that you're reaching, but I wonder how much money is directed to the areas and the people who have the greatest health needs. And so to look at that, I'm like, well, you know, are they taking too much money for hitting the people with the greatest, and missing the people with the greatest needs in the greatest areas? So that's kind of why I was kind of betwixt and between on this question.
Now, Dr. Moody, I love talking to you because you make me think about things in different Moody, but what's your response to that?
Even if you look at the largest mortality rate of central health patients being cancer, my underlying question would be, those are the people you serve.
Right.
I'm concerned with the people that aren't being served, and if we reach more of those, would those numbers shift dramatically? You know, and would it go from cancer to diabetes? Would it go from cancer to high blood pressure because we actually are not reaching that specific population in that specific area or what have you? And so, you know, we're talking about hypotheticals here. I think we have to, one of the things that I'm going to always argue is this: if you tell me the black population is dealing with A, B, and C, I'm going to always ask this question: what was the sampling size? Who did you ask? Because if the sampling size was Charles Moody and Mia Greer, you know, then sometimes, yeah, whatever.
Understood.
But I'm saying, let's say, for instance, you know, we report on the CHIP and the CHA that this is the state of health in this area, and I'm saying, says who? And then when I ask the question, what is that standard that says we have to touch this percentage of the population to get a specific sampling size so that we can actually put together a program that addresses the issue? I don't think we hit that ever.
Right. So that's something then that we need to focus on. So think about, you know, we laid out kind of 3 different approaches to providing health care. It's that middle approach where, okay, we see a certain disparity. And so think ahead to the decisions that the Board of Managers need to make over the next few months. The question is not necessarily focusing on bricks and mortar in any particular area, but of this disparity, is there a strategy that we can fund today? It may not be perfect, but what can we do today to start putting a dent in those numbers? I want to make sure I hear you correctly.
Oh, I think you're hearing me correctly.
Okay.
My issue is what we find is the focus group and sampling process seems to be lacking in the faces that they trust. I've been to, we've been asked to do focus groups and sampling groups, and we've been told, are they going to stay in the room? Because a lot of times they are the people that they or we don't trust.
Right.
And so are you getting true first numbers and then true responses?
Right, understood. And I think you'll see, we had a meeting this morning about the first pass of what we're calling equity data, and it's data that the Community Care Collaborative staff are working on, and it's at a first pass, and there's some there were a lot of questions around it, but you'll start to see us push that information out there. But it's not just a one pass at this information, it's continually updating it. The trust factor is really important. I want to make sure that we capture that and take that back, because if that's influencing the results, and it's not just amongst African American population, it could be Latino, it could be Asian American. You want somebody that you trust to give real answers, otherwise you're getting the wrong answers. And we hear you on that. But I think you'll see us start addressing that equity issue. Now, the one thing that I want to talk about is, how perfect does the solution need to be? Because there's some things that we can stand up with our provider partners today and get going on it, or do we wait until we have it perfected? And that's something that we struggle with internally. I'm of the mind, hey, push out what we can today.
Okay, could you go back to the slide that has the tax burden? That one, yes. Mike, could you spend just a little time explaining to the audience the difference in terms of the central health enterprise method of operation versus what's happening in Harris, Fort Worth for JPS, El Paso, and the others, so that the audience understand that our manner of partnership and providing services, which results in a significant lowering of the tax burden, what impact that has on the population, and helping to understand that the way it operates in other communities are different from here. Could you spend a little time and help the audience, because I think that's important to understand that how that comes about.
Yes, sir. So Central Health, unlike these other urban hospital districts that you see up here, the most unique identifier is that we don't own the hospital. And these other jurisdictions, they own the hospital or hospitals. And I would say the same for the clinic system, because JPS owns their clinic system as well. Everything that we do is through partnerships. We're a relatively young healthcare district. And when you look at also the fact that we have a ministry charity-driven healthcare provider in town, Ascension Seton, they can bring some resources to the table to add to it. When we were formed, the clinics that existed under the city and county, or excuse me, after Central Health was formed a few years afterwards, those clinics rolled in underneath Central Health. And so we have these partners that will fund stuff. We have a clinic system that we did not have to build from the ground up. It was already established and it was rolled into Central Health. And so that gets to Manager Jones's point, which is we're really and truly a taxing and funding entity. Now, we do have real estate holdings that Southeast Health and Wellness Center, North Central, we're looking at other acquisitions in eastern Travis County, as you can see on the map back there on the wall, and what Mr. Wallace had talked about. But having said that, we are rather unique because we don't come to work every day looking at what the hospital operational data is and wondering, is the payer mix right? Do we have enough of the different types of payer funding the hospital care? Our clinic system, we're not the only payer in our clinic system. Community Care and Peoples and others that we partner with, they see Medicaid, they see Medicare patients, they see insured patients. And so there's a lot that we here at Central Health don't own or manage, unlike these other hospital districts. As a result of that, we're able, as Manager Jones pointed out, to have this relatively low rate. If we were to have built the hospital and are building another hospital, we weren't going to let the other hospital providers do that. Or if we were going to be the only payer for our clinic system, this number would be significantly higher. It would be up here with these other hospital districts. And so by using this leveraging strategy that we walked through tonight with some of Lisa's slides, that's how we're able to attain that tax rate. It's an excellent question. Thank you.
So we've noticed an increase in behavioral health issues with the population that we serve at the Housing Authority. I'm wondering if you all have seen an increase, or if that is going to be one of your priorities to provide behavioral health services.
So as I mentioned on the partnership, Screen Integral Care is one of our key partners, and through the Community Care Collaborative, there is 8 million, I believe, is that right? contract for inpatient services that's provided. So yes, that is always going to be a priority. I also think that, and I'd have to defer to those that are in community care or integral care to talk about how we're working to integrate the mental behavioral health and physical medicine. And I know that there's a spectrum on which you fall, that if I have more serious mental illness, then the mental or behavioral health provider may step in and coordinate that care. And then you go to the other side of the spectrum on the physical medicine. And so I know they're still working through a lot of those integrated practice models, but we are currently have integrated practices over there off of Terry Lane, and what's the other one?
So there's 4 locations.
Four.
We have some of our providers in the integral care sites.
Right.
Providing primary care to more of the severe behavioral health conditions. And then within community care sites, just about all of them. In fact, I'm struggling to think of one that we don't have the behavioral health consultants from integral care integrated with our facilities.
And then lastly, to answer your question, thank you, Matt. I know the number of encounters have gone up over the last year. I just don't have the number off the top of my head. We can certainly research that and give it to you.
Howard Falkenberg, I'd like to say 2 things. We are a fairly new system. We started at a nickel and now we're over a dime and taxing. And I think it's incumbent upon you and the board to acknowledge that the community wants to do something about community health and wants to take a part of that, but that you must always be very judicious and very thoughtful with any increases, and you must explain those increases. This is, I think, primarily a meeting of the saved, the washed versus the unwashed here. I'm one of the unwashed, but I think that you ought to think seriously about once, maybe twice a year, doing a really nicely done mail piece and sending it to every household in Travis County to explain what you're doing and the benefits that you're creating and how you're impacting people's lives, so that the whole community that supported this effort in the first place can continue supporting it as you even drive it very thoughtfully ahead.
Yes, sir. So direct mail, if I heard you correctly? Direct mail, if I heard you correctly, that you think is a missing communication MO?
I think people see that when they get the direct mails for candidates in their boxes, and it can have an impact if it's well prepared.
Yeah.
I would argue for that.
And duly noted on being judicious about how all this affects that tax rate. And I know some of the conversations that our Board of Managers has whenever they adopted the tax, or had, when they adopted the tax rate, and probably even, predating me, is they don't just focus on, well, okay, this is $16 per household. They look at the fact that everybody pays property taxes, even if you don't own your house outright. Every time you go to a store, you buy something, you are paying somebody's property taxes for them. And directly through consumer pricing. But also for those folks that are struggling to hang on to their house, they may have been displaced out to eastern Travis County. How does that affect? I think the cutoff that we typically use is $150,000, if I remember correctly. Looking at those folks that are at the lower end of the housing value, how this affects them, because once you start to cross this line where for those that you may be serving, you're driving their tax bill up, you have to be real careful about that. So there's a lot of thought and a lot of analysis and tables and charts that the Board of Managers pours over and doing what you just said, which is about being judicious, but also making sure that we're being fair to those that are struggling to pay their property taxes.
And Mike, it is worth noting that we do use direct mail. Community care uses direct mail to mail particular neighborhoods and zip codes and patients about clinic changes, service expansions, and Mike has actually talked about doing something that you're suggesting, which is a mailer to all Travis County residents. It just gets into a matter of affordability.
If you get pushback, it's going to come from areas that aren't mailed in these select neighborhoods where the services are provided. It's going to come bouncing back from an area that has no vested interest other than the fact that they care about people.
And we do believe when it comes to public education that we need to focus on our patient population, but also Travis County residents in general so that everybody understands where their taxes are going, how their taxes are being spent, and how it's lifting the health of the entire community. So it's a really good point. Frank has a question, and I'm going to have a question of my own I'm going to tee Mike up.
Actually, can we go to the slide that's other, because we're really at that point where we wanted to start capturing things that we didn't ask about yet, because we want to know the next time we, as we start working with the Board of Managers and preparing the budget, having public hearings, what is it that we need to be addressing?
Yeah. So my question is about capital investment, capital improvements. Do you foresee, maybe Larry, do you foresee a capital budget in this year's operating budget? Do you see a list of improvements that you'll be investing in? I know the last time debt was issued probably was the Southeast Health and Wellness Center.
Yes. We presented to the board last year capital projects, but I think in several meetings, if you've watched our board meetings, we have talked about incorporating a more long-term capital strategy, and you will see a lot more information in our budget process this year. So, yes.
So we do want to wrap up tonight by asking you, is there anything that based on what you've heard tonight, is there anything else that you would like, I keep going in the wrong location here, anything that you would like to know more about? And if we can't answer it tonight, we will get back to you. And I do want to also tee up an update about our downtown campus before we wrap up.
Thank you. Thank you for everything. It's been very helpful. So kind of continuing on with the conversation that was happening with this individuals behind me regarding African American outreach. As we know, the numbers seems to be really bad. So I'm curious as to, if there's a plan in place or maybe there's something, I know there's been a lot of conversation about it, but from my perspective, it's an urgent matter where we have to be intentional. And I also think we're late, as far as making sure that African Americans are aware of the wonderful services that are provided, through Central Health and its partners, as well as ongoing communication to let them know what it is, how do they access it, and the benefits of it. So I guess there's been a couple of us who've been on this mantra for years, and it's like, what is the plan? The critical indicator reports is always showing these numbers are low. So I just think that we need to be more intentional, we meaning Central Health, about making sure that these people's health matters and that you're being intentional to make sure that everything they need, they can have access to, at least know about it. It's one thing to know and not do, and another thing to need and not know.
Right. So there's a few things, and not necessarily in order of magnitude or priority, but right now we have a proposal out where we're requesting responses from firms that could help us, or companies, if you will, that could help us with community outreach, and more specifically, using community healthcare workers, which a number of our board members have championed to, you can have all the technology, you can have all the social media that you want, but at the end of the day, if you're not establishing that relationship that people trust, Mia, back to your point, then not only are you losing that individual, but their power of word of mouth you have now walked away from. And so we want to capture that. The second thing is we're looking at the way that we do a lot of our patient education and our outreach, and that's making sure that it's not only culturally relevant, but it speaks the language of health in the way that the individual understands their health, so that you're able to connect with people. A lot of time I hear from folks, I went to go see the provider, and gosh, they asked some good questions. They were really nice, but I don't feel like they get me, And so we want to make sure that last question is never a question. So as we work on our patient outreach, that's going to be critical. You'll hear us on the radio. I know, Manager Jones, you've championed being on KAZI. Larry, you've done that show. I think I'm up tomorrow with Kit, and I want to apologize in advance that I'm one of your co-hosts tomorrow, or Ted's hosting. But I'm really excited about that, because I think that say what you want about conventional radio, it is still a powerful tool. A lot of folks still listen to radio. And I love doing radio, and so I think the more that we can get out there and talk about it and develop that word of mouth is going to be important. Having said that, those are just a few of the things that we're doing, and we can always do better. We can always improve. But it's building that trust where either there was none or building that trust that maybe was lost. Right.
It's an issue of awareness.
And that's on us. Yeah.
Which we're working on. I believe you were on the RFP solicitation for the project that Mike is talking about for the community health workers, community engagement project. So I think that's what Mike is referring to, is trying to work with paid community health workers who don't trust institutions and don't know how to even communicate with institutions, people who live in the neighborhoods, who can talk to their neighbors and their family members about how to access care.
But tell me, what am I missing?
Awareness. I'm just telling you, it's one thing to know, that you exist, and another thing to know you don't exist. And I've spoken with a lot of people who don't even know you exist. Of course, there's all the other things that we've talked about, but
Is it
the
that they
existing
don't
part.
know central health, or they don't know about community
The
care?
partners,
or
all that, they
Peoples or
don't
Lone
understand
Star?
it. They don't see themselves, and they see a lot of the Hispanic community, and they feel like maybe it's something for them, and it's not for them. There's inclusion issues,
Right.
and there's also awareness issues. So clearly, we can talk about this offline. But I'm a community person. I'm out there. I'm always trying to tell people what's available to them, and it's just mind-boggling at as great of a work that you all do, how many people just don't know about you.
All right. Thank you.
That's one of the things that I have tried to champion on the board for Central Health, is how are we reaching the people that do not know about us? Because I've seen that number increase. But the last number I saw was, 196,000 people that were uninsured. I don't know if that captured those that did not know about Central Health or the community care clinic. What I have found within the Latino population, which may or may not speak the language, that's notwithstanding the other 90 populations that don't speak the English language, and how are we going to reach them? A lot of people have not crossed the digital divide, yet we're using the digital component, the tool, to be able to ask them to comment on what we would like to hear from. So one of the things that I'm glad to hear about is that they're incorporating strategies that will reach out into those communities that do not speak the English language, that have not crossed the digital divide. But as we all know, it's going to take 7 touches to reach a community person, a household, to get them to trust you, to interview you. In our population, we're dealing with people who are afraid they're going to be busted and deported and sent to a center and be separated from their children, because their children may be citizens and they may not be, the adults in the household. Those are all issues that are very complex, that are dealing with what we're trying to explain to them is also a very complex issue. The way we have been set up, the way we're structured, the way we provide services, and how we get them to engage with them, to enroll in our system so that we can reach them and provide them services that they have historically not been able to access because of all the barriers in place. One of them being the clinics that didn't exist east of 35. There were just very few that were there. Now we're talking about realizing the reality of bricks and mortar and modular clinics and vehicular clinics that will be able to move and provide them services. But everybody is right in that we need to do a better job of making sure that they know that we exist and how they can contact us to access our services. So maybe we need to go back to Ted's famous billboards, but put them out there in the neighborhoods where we know the greatest needs exist. Maybe we need to do the communication campaigns by those that are experts in hard-to-reach populations. So it would be a mixture of interventions, a mixture of strategies that would have to be utilized in order to reach those people in our neighborhood, and know full well that there are many, many, many more that need to be reached, but that we can provide their services to them.
I think Mia had a follow-up.
One thing that we have done with the Black community is we've gone to the churches. because one thing we know, if the pastor says it in the pulpit, then the people will follow. I went to one church who quite a few of them couldn't even write or read. So they're not going to be able to get on the computer to fill out a form.
Right.
So I had to actually sit down with them and read them the question and ask them, do you want it to be this question, answer, this answer, this answer? Some of it is just that basic to reach some of the population that Central Health has not been able to reach.
And so let me just say it a different way. And this is something that Mr. Wallace has talked about quite a bit, but reaching out through the faith-based communities, and I would say it crosses all different faiths on that, but I think that's particularly important. That's not something that you see government organizations doing, but it's something that I think that we know that if you're going to reach people, you have to go to where they live, work, play, and pray. And that's one of those places where we need to do a better job at. I agree.
Mr. Gieselin, and you know what's coming.
Oh, please call me Mike.
I'm sorry?
Mike.
Oh, Mike. Okay. All right, Mike. You know what's coming. I want to know how we're doing on collective A1C, hypertension, triglycerides, cardiac panel, also getting people moving. And then one idea that I have, because I know that there's a strong correlation between, A scores, behavioral health, and then, of course, cancer as well as other chronic diseases. The possibility of, at the primary care level, possibly having some in-house ATCIC process groups, also possibly having funding where we could partner with SAFE, even for men's processing groups, because I know that's definitely a need here in Travis County. So I just wanted some feedback on that, if I can.
So I will admit I'm way out of school when it comes to talking about clinical measures. However, on the CCC website, so it's ccc-ids.org, or you can get there through the Central Health website. And we've got a couple of computers here. We can show you how to get there. But we have those clinical dashboards, and they're for everybody to see. And we've got benchmarks that we've recently set. I say we, working with our clinical partners. And some of them, we have a long way to go still. Some we're hitting those benchmarks, but we're starting to do exactly what you just said. Yes. Any other thoughts? Or again, as we head into this budget process, we know that we can't come up with all the questions, and so this really helps our board of managers and staff as well. I really appreciate the feedback on the outreach, and I know there's an RFP on the street right now, but I think once we get going on that, you'll start to see some different outreach approaches, and we're going to learn. Is it going to be as much as we should do or need to do? We'll never be able to do enough, but we're going to learn and get better at it as we move on through project to project. Anything else? All right, so lastly, on the budget timeline, down here at the bottom, you have some other opportunities. So we have an online budget engagement survey. It's got a number of questions attached to it. So that'll be online now through May 31st, the end of May. And then June 19th, we'll post this report on our Central Health website. And we have a special subsection of the website. Is that how you're supposed to say that? It's the centralhealth.net website /2020 budget. And July 29th, we'll have another community conversation where we actually bring the proposed budget. This was just kind of a first pass at here's what we're thinking, here's what we're seeing, what do you think? On July 29th, we'll actually have the proposed budget. It'll be a set of numbers that you can react to and you can see, oh, here's how they're going to spend money on hospital care or clinical care or community outreach and engagement. On August 28th and September 4, we'll have the budget public hearings. This is both for the tax rate as well as the proposed budget. And we'll have citizens communication for those as well. So if you can't jump online, can't make it to the community conversations, we still have the public hearings. Having said that, if we'll stick around here afterwards if there's some things you want to visit with us about or ask us about.
And Mike, one last plug. We have a community conversation on May 20th about the Central Health downtown campus, and there's more information at the bottom of your agenda, so we hope that you can join us for that as well. Clicker.
Oh, yes, please leave your clickers. They're not old school cell phones to take home. But thank you all very much for coming. Your input's very valuable. And please encourage folks that have access to online to take that online survey. We'd love to hear from you. Thank you.